endocrine therapy has been a targeted therapy from its development, except that the oncology world was not using that terminology, but it was the perfect model. You had to identify the target, in this case patients who had expression of the estrogen receptor. You would do that routinely in the clinic. You had a validated test. If the patients did not express the target, you would not use hormonal therapy. If the patients express the target, they have a very high probability of achieving benefit from the endocrine therapy. So it might have clearly been a targeted therapy. It's just not a fancy targeted therapy. But what I think is happening now is that we're developing new targeted therapies that we're combining. An important one that I hadn't talked too much about, but is combining endocrine therapies with HER2 inhibitors. It becomes a small subset of patients, but there's randomized trials showing that either using trastuzumab or lapatinib in combination with aromatase inhibitors clearly improves the efficacy of the hormonal therapies by themselves. So I think we're becoming better at understanding the hormonal therapies as targeted treatment. We still have to understand better the mechanism of resistance. So why is it that there's a subset of patients who never respond to hormonal therapy? They have primary resistance to hormonal therapy. And why is that virtually every patient with that's responding to hormonal therapy in the metastatic setting will eventually require resistance to it? That's where we're still in a very early process. The mTOR inhibitors appear to be focusing on that pathway, but we still have not developed a validated diagnostic assay to identify which patients will benefit from adding an mTOR inhibitor and which ones will not. So those are the areas where research is currently being conducted.